Good day and welcome to the Seeing is Believing Africa regional webinar. My name is Susan Evans and I'm the Seeing is Believing Project Officer for IAPB. The theme for this Seeing is Believing webinar is human resource development, and we have some fantastic presentations for you today. Thank you all for attending. I really appreciate you taking the time to join us and be part of our learning community. We have over 37 people registered from 10 countries in the region, which is fantastic. If you would like to introduce yourself to the group today, you can write your name and which country you are from in the chat box on the side panel. And I'd also like to say a big thank you to our webinar presenters today. So we've got Simon Day, the Africa Programme Coordinator for IAPB, Dr. Juliana Nathaniel, the Programme Director, Seeing is Believing Nigeria CBM. We've got Kezi Nadu, the Southern Africa Sub-Regional Manager, Brian Holden Vision Institute, South Africa. And Kezi is kindly standing in for his colleague, Parinda Govinda, who is unable to attend, unfortunately. So the agenda for the webinar will be, firstly, welcome and housekeeping notices from me. Secondly, an introduction to the opportunities and challenges to human resource development in the Africa region by Simon Day. Thirdly, a presentation on human resource development in Seeing is Believing projects by Dr. Juliana Nathaniel. Fourthly, a presentation on human resource development in Seeing is Believing projects by Kezi Nadu. Fifth, after the presentations, I will chair a question and answer session. And I aim to wrap up the webinar by the end of the hour. So as I mentioned, the theme of this Seeing is Believing webinar is human resource development. The presentations today will share successful human resource development strategies from their Seeing is Believing projects, and we hope that webinar participants will be able to identify strategies which could be used in their projects. So I'm now pleased to introduce my colleague, Simon Day, the Africa Programme Coordinator for IAPB, to give an introduction to some of the challenges and opportunities of human resource development in the Africa region. And Simon, I'm just going to make you the presenter.
Thank you, Susan.
Thanks, Simon.
Great. Right, human resource development has been a major focus for IAPB Africa for quite some time now. The majority of countries in sub-Saharan Africa face a severe crisis of skilled health workforce shortages that impedes the realization of universal health coverage, especially in specialized fields such as eye health. Globally, 57 countries failed to reach the minimum desired level of coverage of health workers, and 36 of these countries, unfortunately, are in sub-Saharan Africa. Health workers really are the heart and soul of health systems, and yet the world is faced with a chronic shortage. It's estimated that 4.2 million health workers are needed to bridge the gap, and 1.5 million of these are needed in Africa alone. I'd like to quickly refer to some human resources for eye health data from the IAPB Vision Atlas. The Vision Atlas is a website, is a compilation of the latest eye health data and evidence, designed around two main sets of data. The estimates of burden of blindness and visual impairment made by the Vision Loss Expert Group, and the national level performance indicators against key indicators laid out in the Global Action Plan. What you're looking at here is a box and whisker chart from the IAPB Vision Atlas. These charts show how the inequitable distribution of the eye health workforce is clearly apparent, with the majority of African countries experiencing critical health workforce shortages. Here, you're looking at the number of ophthalmologists per million population, and you can see the very small box right near the zero line axis, and that is sub-Saharan Africa. The shortage of eye health workers at all levels in sub-Saharan Africa is particularly alarming. For example, the region has less than 50% of the minimum number of ophthalmologists required to meet the needs. Here is a similar chart, and it shows the optometrists. Now, these are the optometrists per million population for the 128 countries that participated in this exercise. And again, you can see that sub-Saharan Africa is right on the close to the zero line. Similarly, the allied ophthalmic personnel for 95 countries for which data was available. And here, this chart shows the cataract surgical rate, which describes the CSR describes the number of cataract operations performed per year per million population, and serves as a quantifiable measure of cataract surgical service delivery. It's true to say that countries with a CSR of less than 1,000 are almost certainly falling well short of the required number of cataract surgeries to prevent avoidable cataract blindness. And those with a CSR of less than 500, lamentably so. And you can see that, unfortunately, sub-Saharan Africa falls there. Excuse me while I break for a sip of water. In an effort to strengthen human resources in the region, the IPB Africa Human Resources for Health Strategic Plan has 3 immediate objectives. The first is to integrate the eye health workforce planning into broader human resources for health planning processes. The second, to develop a set of competency frameworks for the different levels of the eye health workforce. And thirdly, to strengthen the strengthening of eye health training across sub-Saharan Africa. We've always said that to deliver effective health services and improve health outcomes in terms of eye health workforce, it's critical to have the right number of health workers in the right place at the right time and carrying out the right skills. IPB and members have been investing in strengthening the eye health workforce in sub-Saharan Africa for many years, and the success of the strategy is highly dependent on an enhanced level of coordination and a greater synergy between our member agencies and strategic partners. In that regard, we have been working for a few years, and so have our members with Seeing is Believing. And beginning last year, we began a project with Seeing is Believing on building capacity for low vision practitioners and ophthalmic nurses in sub-Saharan Africa. And a little later in this webinar, you'll be hearing from our colleague from BHVI, Mr. Kesi Naidu, who will tell us more about this strengthening capacity amongst low vision practitioners in sub-Saharan Africa. Thank you, Susan. I'll hand back to you.
Thank you, Simon, for that insightful overview. And the IPB Vision Atlas data really shows where there are gaps within human resources within the region, and it's a really interesting tool that if you haven't had a look at already, then I would really recommend that you going online and having a look at that for our attendees. Thank you. Right, so for our next presentation, let me introduce Dr. Juliana Nathaniel, the Programme Director for Seeing is Believing Nigeria for CBM. So Juliana, I'm going to make you the presenter now.
Okay, thank you very much, Susan. And the presentation outline, this afternoon includes the following: needs assessment of staffing gaps, identifying skill shortage, and filling of the gaps, and different methods of human resource, for health development. Then we'll talk about developing curriculum and models within national standards, and then identifying partners, challenges, and how these were overcome, and staff retention, career development pathways, and continuous professional development, as well as sharing of useful resources. That's the presentation outline for today. And the Comprehensive Child Eye Health in Nigeria Seeing is Believing program is managed by a consortium comprising of CBM International and Brian Holding Vision Institute, as well as partners. Now, the project has 6 objectives. Now, the first objective is developing skilled and adequate manpower to provide comprehensive child eye health services at various levels of healthcare in targeted project areas. We also have improving quality, accessibility, and scope of child eye health services. We have another objective that talks about embedding child eye health in policies and programs of the Ministries of Health and Education. We also have the objective that talks about piloting strategies for inclusive eye health, and then establishing school eye health program as a sustainable model to deliver child eye health services, and finally improve the quality of early intervention and education of children who are blind and with a severe visual impairment. Now, this presentation, like Susan mentioned, is going to center on our first objective, which is develop skilled and adequate manpower for provision of comprehensive child eye health services at the various levels of care in targeted projected areas. Now, the Seeing is Believing program is working in 11 states out of 36 states in Nigeria. Now, if you look at the map, that is attached, we're working in the Northwest, and we're covering Katsina, Kano, and Jigawa. We're also working in North Central. Here we're covering Plateau, Nasarawa, and the Federal Capital Territory. We work in Southwest, where we cover Oyo, Ogun, and Osun State, and also work in South-South, where we cover Cross River and Calabar. Now, the objectives for this presentation, of course, will be to know the human resource development tools and resources available, and then learn about successful strategies and identify strategies on human resource development, to use in our various projects. As part of background information, Nigeria has a population of 189.9 million people. We have 36 states and the Federal Capital Territory. Eye health is not a priority for the government of Nigeria, and then few eye health specialists are available in the country. Now, there's no eye health policy. Primary healthcare training manuals does not contain sections on eye health, and the National Primary Healthcare Development Agency does not have eye health as part of the minimum service delivery package. Now, I'm talking about the eye health policy. The government is working hard, and I'm sure that within the next few weeks or months, the policy on eye health will be out, for Nigerians. And, we conducted an assessment at the beginning of our program. And one of the things we tried to find out was to find out if any of the providers were trained on eye health within the past 2 years. And of course, looking at the secondary and the tertiary facilities, we observed that most facilities, have not trained staff within the past 2 years. And under cluster 1, we also recorded about 28.6%, saying that they have been able to access training. But for the other clusters, none of them had been trained, over the past 2 years on eye health. We also looked at issues that are related to child protection. And of course, most of them were not even aware of, the child protection policy, and are not, trained, on child protection. Now, part of, the work that we did at the initial stage was to identify gaps in human resource, for health. And by that, we conducted a health facility audit and then also determined training needs, within those facilities. Now, some of our findings are as follows. There were no pediatric ophthalmologists, in most of the facilities that we surveyed, except for the tertiary health facilities. We also discovered that optometrists were mostly available only at private and secondary and tertiary health facilities. We didn't have them at the primary healthcare facilities. And there were no skilled eye health providers at the primary healthcare facilities within the facilities that were surveyed. Now, we had, it was a big challenge, because that was a big gap for us. We needed to deliver services, we needed to reach the people. So we had to initiate action immediately. And then what we did was to train human resource for health, working in various cadre actually. And then in conjunction with the National Eye Center, we went in to conduct a training of trainers workshop for 29 ophthalmic nurses using the competency-based model. Now, the trained ophthalmic nurses, those that were trained at TOT, conducted their cascade training for other ophthalmic nurses. They conducted for community health extension workers, and also conducted a training of trainers for teachers. Okay, now the trained teachers cascaded training to 4,400 teachers. And community structures, those are the traditional birth attendants and community direct distributors were trained by the partners. Then we had specialist training, training of optometrists on refraction and low vision, and orientation, to pediatric ophthalmologists. That was done by the tertiary institutions. So that was, the trainings, that we embarked upon. So we trained, different cadre, at different levels to ensure that services are provided, depending on the cadre of, individuals that are needed. Now, before we did that, we had to adopt a training, training models kind of, that are within national standard. So what we did was to do a manual adoption meeting, with eye health stakeholders in Nigeria. Now, apart from that, we were able to adapt those manuals in part, that were developed by WHO. We adapted manuals that were developed by Brian Holding Vision Institute. We also do, partly adapted manuals that were developed by CBM, Sight Savers, and then the Federal Ministry of Health to address various aspects, based on the gaps that were identified during the training needs assessment. We also went ahead to develop tools for post-training supportive supervision so that those that are trained, could be mentored and coached, by the teachers or the trainers, until they're able to, develop competence and then move from competency to proficiency. And we were able to, when we came in, we needed to identify partners that will help us, develop human resource, for health. And then the first organization that we contacted was Arabind, Training Center in India, to help us train additional ophthalmologists under the program, to put a short program together and then train them maybe over a period of 6 weeks. Unfortunately, they were busy and they were not available to help us do that. Now, we also explored the Nigerian Pediatric Ophthalmology and Strabismus Society, to see if they could help us, train ophthalmologists. Unfortunately, they had a very robust, kind of program. And of course, we discovered that by the time we engaged them to do those trainings, that the program will have, ended, and then those that are on training wouldn't have, finished the training. So that wasn't an option for us. And then we now engage with the National Eye Center in Kaduna, who conducted the TOTs, and then government, tertiary institutions, who did the specialist training, and then other SiB partners who went ahead to, support us in training community-based providers. Now, some of the challenges that we encountered, and how we overcame them was, I think that the major challenge that we had at the onset was working with the government and ensuring that the government, is committed, because, the project is not going to be a, continual, it's not going to continue, kind of, and that we needed to ensure that even at the onset, that we build in sustainability and ownership. So what we did was to share reports, of the health facility audit that was conducted with the Federal Ministry of Health and even the state ministries of health, so that they will see where the gaps are. And apart from the reports that we shared, we had to, agree to work together. So we had to put the government on the driver's seat. And of course, we worked together to agree on training manuals, that will be used. And apart from working together on the training manuals to be used, we also agree on where training, should hold, that is site, and who should conduct the trainings. And then we selected health facilities and schools in conjunction with the government, and then identified ophthalmologists, optometrists, ophthalmic nurses, choose teachers to be trained by the government. Okay, so government were actually driving the process. So they were the ones that carried out all the necessary activities, and so that ownership will be there. Then we also agreed that they will participate in monitoring of all the trainings, and then also involve them in developing the post-training supportive supervision tools and performance monitoring tools that we are using under the program. Now, regarding staff retention and career development pathways, we had to sign an MOU with the government to coordinate healthcare workers transfer, under the SiB supported facilities. That simply means that, government, we cannot stop them from, transferring staff. However, when they are about to transfer staff, they should consider transferring staff within the facilities where the interventions are going on so that there will be continuity. Then one other things we agreed on was that health workers that have less than 5 years left in service should not be trained, so that after a few months of training, most of them wouldn't say that they want to, retire and go, and then will have lost out. And then we encourage eye health workers to engage or, register for online courses, the Global Eye Health, program. And then finally, health institutions, where we discuss with health institutions, to incorporate eye health into their training curriculum. But this is a long-term measure. And of course, we are not able to, do this, or support them to do this. But, we've encouraged them to explore other options, so that they will be able to do this, so that we can have it, as part of the pre-service training. Some of the useful resources, that we have, generated during the course of this program include a post-training supportive supervision tool. We have a performance standard tools. We also have guidelines for child eye health treatment, and then we have an algorithm, for management of eye health condition at the PHC level, which of course we adapted, from the WHO manual. So thank you very much for listening. Susan, thank you.
Thank you, Dr. Juliana, and a really interesting presentation. And I especially liked the fact that you highlighted the importance of conducting the baseline and also sharing with us how the project developed the curriculum, identified partners, overcame challenges and introduced staff retention strategies. Really interesting. And also the aspect of training the whole team and using that cascade training to make sure that you're reaching everybody who's going to be involved in the project. So thank you ever so much for that. So thank you, Dr. Juliana. And thirdly, let me introduce Kezi Nadu, the Southern Africa Sub-Regional Manager for BHVR South Africa. And Kezi, I'm going to make you the presenter now.
Good afternoon to everybody. As indicated by Susan earlier, I'm delivering this presentation on behalf of my colleague, Prinda Govender, who's unable to be with us today. We're talking about the capacity building for low vision in Sub-Saharan Africa project, which is a partnership with IAPB Africa, the Brian Alden Vision Institute, and funded by Seeing is Believing. So to start off with, the low vision working group of the IAPB has estimated that 80 million people with permanent visual impairment can benefit from low vision care, with 6 million of them being children and 4.8 million of them living in low to middle income countries. Lack of vision significantly affects learning, and in the case of children with low vision, it is amplified. The majority of educational environments are not equipped to manage children with vision disabilities, and therefore there are significant limitations in academic attainments. Limited educational opportunities subsequently result in limited job opportunities. Persons with disabilities are more likely to be unemployed and live in poverty and face social exclusion. Considering the significant impact, we need to ensure that the appropriate interventions are made to enable people to function within their educational, vocational, and recreational environments despite their vision impairments. In trying to ensure that the appropriate human resources is provided for patients with low vision, the Low Vision Working Group of the IAPB presented the following commonly cited constraints and challenges. Inadequate human resources, the quality of training may not be of desirable standards, the lack of standardized curricula and master trainers in the regions, resource centers for training do not have sufficient training materials and equipment, and insufficient exposure to practical work. Furthermore, a study in Kerala, India, by Yosei et al. Investigated the awareness, knowledge, and barriers to low vision amongst eye care practitioners and found that among the most commonly cited barriers to practitioners providing low vision services was lack of training and affordable low vision devices. In addition, almost 90% of practitioners who were interested in doing a short course in low vision found that there was limited access to training opportunities. So we needed to take this into account when the call for this proposal came out. So the project sought to establish low vision as a subspecialty in optometry in sub-Saharan Africa. The goal of the project is to create competent, well-trained and motivated teams of low vision trainers and to create a nucleus for expansion of low vision for sub-Saharan Africa, and also to foster cross-sectoral linkages so that low vision services are able to take on a team approach rather than one in isolation of other factors that need to be considered. I think here we need to bear in mind the role of other providers besides eye health practitioners specifically. The specific objectives: to develop the capacity in sub-Saharan Africa or in SA to train 4 low vision educators, to develop a 1-year modular African low vision curriculum, provide scholarships for candidates, develop low vision training programs in South Africa and Nigeria, to develop an integrated and ongoing low vision practitioner training program for sub-Saharan Africa, and to obtain AFCO endorsement. AFCO is the African Council of Optometry. The reason why we are taking this approach is the majority of eye care practitioners are not trained in low vision management. Low vision training within the programs or within the academic programs are usually focused on clinical care and prescribing low vision aids. The practitioners focus more on vision improvement and provision of low vision aids than other aspects of low vision care, being rehabilitation, recreation, education, etc. Low vision management is not a priority of most district health departments, and a need exists for sustainable low vision training from undergraduate education to continuing professional development initiatives. Current low vision training has not included recreation, rehabilitation, education, or has addressed it in a limited way. Furthermore, it doesn't conform to needs and aspirations of patients and is centered on prescribing low vision aids. And so this comprehensive low vision master trainer program was born, which will be accredited by the University of KwaZulu-Natal as a master's level program with over 1,100 hours of credit. The course will also be endorsed by AFCO. The objectives of the course are to develop master trainers in low vision in sub-Saharan Africa, develop advocacy skills in low vision in sub-Saharan Africa, develop effective trainers in low vision in sub-Saharan Africa, and develop research capacity in low vision in sub-Saharan Africa. There are 4 participating institutions. 2 are in Nigeria and 2 in South Africa. These 2 in Nigeria are Abia State and University of Benin and the Universities of Johannesburg and KwaZulu-Natal in South Africa. The selection of candidates has already taken place and they are currently being orientated for the first iTeach module. So there are 4 core modules to address the needs. iTeach refers to a program of capacity development in teaching for eye health professionals. So it introduces optometrists and other eye health professionals to the didactic concepts that underpin teaching and explain and allow them to be able to teach better from that perspective, but also exposes them to management, research, teaching of clinical specialties, amongst others. Then there'll be low vision, advocacy, and research. Just taking a closer look at the program overall. So the first part is the iTeach, which is, as I've indicated earlier, is a strategic teaching development program. The participants will work through modules, participate in online discussions and interactive calls with course facilitators, fellow participants and global leaders, and complete assessments that will enable their teaching practice. The second component is the low vision theory and practice, which will concretize baseline knowledge in low vision theory and practice so that effective clinical care can be provided. Experts in inclusive education, rehabilitation, and environmental adaptation will be called in to deliver relevant components of the course. Due to the limited number of dedicated low vision centers with adequate infrastructure, equipment to support low vision care, and the volumes of patients, candidates will be sent to the prestigious LV Prasad Eye Institute in India for the clinical rotations, where up to 60 patients are seen per day. They will be able to provide care at all levels of service delivery. They will also be able to interact in educational and occupational environments which have considered inclusivity of patients with low vision, working with and within a team providing the gamut of services that constitutes comprehensive low vision care. On returning to their home countries, they will be providing low vision services, putting into practice all they have learned. And then to contextualize their low vision experience, they will embark on a 2-week field practice in an African country. It is envisaged that the 4 faculty engaged in this program will take low vision training and services on the continent to the next level. Thank you.
Thank you, Kezi, for sharing the barriers to practitioners providing low vision services and explaining a little more on the aim to establish a low vision as a subspeciality of optometry in sub-Saharan Africa. The iTech online course sounds particularly interesting, and thank you for giving us that overview. Really interesting presentation. Okay, so we have now had quite a few questions coming in. So I'm going to try and group them depending on what kind of question it is. So I'm going to start by, we have I'll give you a couple of questions, all of our presenters, and then you'll have a chance to respond. So the first question that we have is for Dr. Juliana. And it's from Francis Colasso, who's asking, could you elaborate more on the competency-based model approach that you talked about in your presentation? And second question is from Coronel Kema from Tanzania. And he's saying low vision is now with interest considering the situation that exists on the continent. And what measures are you putting in? This is, I think, more for the Brian Holden Vision Institute. What measures are you putting in place to support the training institute to conduct the low vision training course? So if we begin by asking Dr. Juliana, do you want to take that first question about the competency-based model approach? You can unmute yourself and then if you can answer that first question, and then I'll hand over to Kezi and Simon jump in around the second question around the support that you give the Training Institute.
Okay. The competency-based model, was adopted, like I said. And how we actualized it, was, to engage, trainers, fully, as in after the, classroom session, which is the didactic session, we had the practical sessions, which is, hands-on. And then in that hands-on, each of the trainees, were engaged, one-on-one, so that, we are sure, that trainees normally don't learn at the same pace. So each one of them was engaged one-on-one, to ensure that they attain competency. Then after they've attained competency, the trainers, still follow them up with the post-training supportive supervision tool, to watch them in the facilities, practice, some of the skills that they have learned. And then they were there, to provide them with, mentoring and coaching, to ensure that they have mastered, the skills, So that is, the competency-based, model that we adopted. So it's not just like the ordinary, training, where you come to the, classroom setup and then you do the didactic and then you finish the didactic and then the person goes away and then continues, nobody follows up. So this one, there was a built-in post-training supportive supervision mechanism, so they are followed up and they are not going to be certified until each of them has been certified as competent, in the performance of a particular skill, So over a period of time, we've been following them up, and we can only certify them until they have, proven to be competent. And the reason why we are doing this, is that we have discovered that, in most cases, when providers go for training, they go back to their health facilities and they are unable to initiate services. So this time around, we are being very careful to ensure that after they have been trained, that someone provides supportive supervision and that they are able to, perform this task, for which they were trained on. So that is the competency-based model that we adopted. And of course, there are, checklists, that are used, to ensure that procedures are performed in accordance to approved quality standards. So that is the competency-based approach that we adopted.
Thank you, Dr. Juliana. And that sort of hands-on training is so effective, and actually getting people to practice can make it a lot more effective than just a sort of, chalk and talk method. So excellent. Thank you for sharing that with us. And then the second question then to Kezi on the support for the training institution. Over to you, please.
Thank you for that question. I think we must, just to understand, the objective of this is to start to develop capacity for low vision training and master trainers in the region. And while we might not necessarily reach every training institution in the first round, we see these two centers or these 4 centers that we established now as being the first phase, and the master trainers that are based at those centers then delivering the capacity development to other institutions through their faculty, or their delivering courses at those institutions, or faculty from those institutions attending of courses that are delivered in these institutions. The institutions, when this project ends, the idea is that these institutions will be in a position to deliver a high-level low vision course through the master trainers that have been capacitated with the necessary equipment to facilitate that training program, and also with the necessary access to the other resources that would be required. For example, low vision devices, access to other IELTS or other healthcare or other professionals that are required, your psychologists, your social workers, mobility, and all of that. I think that's where we see it as going to in the future. So the plan is to reach every institution starting from these 4. Thank you.
Great, thank you, Kezi. So it's also around the selection process, I imagine, to make sure that the institutions you choose already have some capacity to be able to deliver the training.
That's true.
Okay.
I think when we maybe just to give you some added information regarding the reason why we chose the 2 countries in particular is because Nigeria and South Africa have about the largest population of optometrists on the continent. So we started with those countries because there is a much a bigger available pool of optometrists also. Not to say that the other countries would not benefit from that, but we saw that as a good starting point. And of course, factors around what is available were considerations in developing selecting particular institutions, and even the faculty that are are selected to be master trainers, I've gone through a process as well.
I see. That makes sense. Thank you. And actually, there's a question, I think a little follow-on question on that same issue from Amala Erdman, who's the CBM regional advisor in Lomé, Togo, which is around once the for the low vision project, once the master trainers are ready to train, how many trainees from other countries do you think will be taken on per year?
It's going to be dependent on the individual situations, but I don't see there being courses that are delivered to a huge number of peoples. So you would probably need to look at it, in the first, within the 3 years of the project, there's the plan is to get to, I think it's about 20 additional trainers, additional low vision people trained. That right now we can start to see how many other countries can be included in that. I think if you look at it, part of it is also going to be the availability of the resources within a country, bearing in mind that all of these low vision services can be quite resource intensive to set up. However, if there are agencies working within countries that have a particular interest in an area and they are prepared to support, I think it will be easier to be able to put together programs to address that need. It's going to be a matter of making available this resource and looking at how we can, as quickly as possible, cascade it to as many different countries as possible.
Excellent. Really exciting times, actually.
Thank you.
Okay, thank you. So just a reminder to our listeners, if you have any questions, please do put them type them down in the chat box, because we will be finishing at within the next 15 minutes or so. So you don't have long. If you do want to ask a question, please do type it in and we'll ask it. And actually, one question from me, we talked a little bit about the selection of the training institutes, and obviously Dr. Juliana, you mentioned in your presentation quite a lot around some of the challenges of working with some training institutes, but I wanted to ask around the actual the staff to be trained. So how, within the project, how did you identify the staff to be trained, and who made this decision, and how did you manage issues like getting permission for them to take leave for the course and that kind of thing? So I think if we start with Juliana, and then Kezi, I'll move on to you if that's okay. So, Dr. Juliana, I think you just need to unmute yourself.
Very much, yeah.
Yeah, sorry, Dr. Juliana, over to you. So how did you decide on identify the staff to be trained, and who made the decision?
Yeah, like I said, we had to, put the government at the driver's seat. So, we had, several meetings, and then we agreed on who should be trained at what category or at what level. And, the government, felt that the right people who should do the training, for ophthalmic nurses, for community health extension workers, and also for others, we are the ophthalmic nurses that are working in the various, facilities within the states. So they identified and nominated the people who will attend the courses, and then they came in for the training of trainers, workshop, and they were trained. And of course, we had a discussion, that for specialists to be adequately trained, that they have to be trained by people working at the tertiary health facilities. So professionals, at the tertiary health facilities were the ones that trained, the specialists. That is, the optometrist, on low vision and refraction, and then also gave an orientation to the ophthalmologist, sorry. Now, what I'm saying in essence is that a decision on who to train was taken by the government, and of course at the federal level, and then at the various state, government, levels, they identified the people to be trained, and in fact they went as far as saying, okay, this is the place where the training should hold. Even the sites were identified by the government. So the government were at the driver's seat, and they decided on who needed to be trained at what level, and that was how we did it. So we didn't just decide that because we don't know the people. They are the owners of the human resource that we wanted to train. So we had to rely on the government to tell us who needs to be trained and at what level that training should hold. So that was what we did at our own end, under the SiB program in Nigeria.
Yeah, that makes sense. And I suppose because it's being led by the government, they were then able to release people for training and that kind of thing.
Exactly.
Yeah. Okay, great. Thank you, Dr. Juliana. Okay, Kezi, over to you. Same question.
Thank you, Susan. Yeah, a pretty easy answer, right? Look, we had two things to consider here. Firstly, we had to consider the institutions, right? So if you look at the countries, we had identified the countries, and both these countries have more than one institution. So we had to look at the institutions and select institutions based on their willingness in the first place to participate, their readiness to participate, the resources that they already had available. And then when it came to the participants themselves, the master trainers that they would be sending through the program, the institutions were asked to send us two names at least from each, two potential candidates from each institution, so that we could select the candidates. We're also in the process of developing agreements with the institutions and with the candidates to ensure that upon completion of the training, they go back and they function as we do envisage that they will function. Bearing in mind that these are employees of universities, and if somebody decides to leave, we're going to have to find ways to manage that situation. But in the selection process, we've tried to mitigate these factors as much as possible. So we believe we've been able to select candidates from institutions that are supportive of the program and will stay on for the long run and are willing partners. And bearing in mind that these are not institutions that the institutions that we're participating with are institutions that we have had relationships with over many years. These are schools of optometry that we've had various other partnerships with them on other different aspects. So it's not that we are working with organizations or institutions that we have not known before. So there is also that advantage. So we have selected them based also on the working relationships we have with them. I hope I've been able to address you.
Yes, no, that's clear. So part of it is already having the relationship already with the institutions, and that quite nicely leads into our next question that we've got from the audience from Kema from Tanzania, which is around sustainability with reference to the retention. So obviously, Dr. Juliana, you had a sort of slide on staff retention and career development pathways in your presentation. So could you maybe talk a little bit about what did you find were the most effective strategies in terms of staff retention having gone through the training? And then I think the same question to Kezi, although you've touched on a little bit. What are the things you need to put in place to try and encourage staff retention? And then to our attendees, if you have any final questions, please do type them in, because we will be closing in a little bit. So any burning questions, please send them in. And Juliana, over to you. What do you think in terms of the staff retention would have been the most effective strategies? If I just unmute you, I think you might be self-muted. Juliana, yeah, over to you.
Yeah, in terms of staff retention, Like I mentioned during the presentation, I mean, this is a big issue for us, especially in programs. We have seen instances, where you train healthcare workers, and after training the healthcare workers, maybe 2 to 3 months or 6 months down the line, that health worker is removed and transferred to somewhere else, where the program is not, happening at all. And, I mean, it becomes, an issue, it creates a lot of gaps and so on and so forth. So what we did was to enter into an agreement, an MOU with the government, to agree, yes, that they will transfer staff. However, that those staff are going to be transferred, within the intervention facilities where the SiB program is working, so that we can have continuity, in the program up till, the end of, the program period. So that was how we, dealt with that. And apart from that, we also had to, give them, some selection criteria, for those people who are going to attend the trainings. Now, one of the criteria that we gave them was that nobody who has less than 5 years in service, should be selected to participate, as a trainee, for the program. And of course, because if they have less than 5 years, even before the program ends, you discover that most of them are already resigning and then leaving the program, and so, or retiring and leaving the program. So what we had to do, was to ensure that, the younger ones are the ones that are trained, who have a longer time, to stay in service. And I think that, so far, that is what we did, to ensure that, we have staff, retained, where they were trained. And to also mention that, the reason why we have to embed the program, within the government system is because we want to see sustainability happen. Because, I mean, if we don't do that, by the time you know it, I mean, the program will come and then the program will end, and then you won't feel any impact, about, the program that had just ended. So it has to be embedded, within that government system, so that government will take ownership of the program, and then drive the program and be able to sustain it. Like, most of the people who were trained were from public health facilities, so those staff belong to the government, and the government are already paying them, so they are there, as a part of, a system, that is already ongoing and running. And I think that those are some of the things that we did, to ensure that we have, staff retention and that there's continuity, in the program, even well after, the program has ended. Thank you.
Thank you. Yes, that embedding within the system and strengthening the system is a really key component of sustainability. So no, thank you for sharing that. That's really interesting. And then Kezi, over to you about, you've talked a little bit around staff retention. If you could talk a little bit more about any other things that the project's thinking about, or what you need to have sort of in advance.
Okay, I think with regards to the sustainability and retention of staff, the trainers, the reason why we took the approach of going with the university training program is that faculty in the university generally tend to stay there longer. One of the factors that contributes towards faculty remaining at a university is if they are able to proceed through their postgraduate studies. So the objective in setting this certificate course at a master's level, while it doesn't necessarily provide them with a master's qualification at this point in time, is that it allows them to use components of this program in a future master's that they may want to pursue. Mm-hmm. So it makes it easier to retain them if they have the masters, because most universities now are insisting on even PhD as a minimum for teaching. Also, when we look at selections, the factors considered in selection is, did this person have an interest in low vision? Are we not? We want to be sure that we're not pushing somebody in a direction that they're not necessarily keen on. Also, if you look at the fact that through this, we expect to have a much more robust undergraduate low vision training program even, because these trainers will also be training the undergraduate programs at these universities. It will introduce all new generations of graduates, or optometrists and other IL practitioners moving through the system to low vision in a different way, and through that produce the future low vision educators that can be groomed by these very same master trainers in the future. So these are what we've considered with respect to staff retention and sustainability. Thank you.
Thank you. And again, it's that sort of similar strategy of kind of embedding it within the system, so they know that if they have the credits from this, it can go to something larger if they're going to do a PhD or something. No, really interesting. Thank you, Kezi. Right, so that's pretty much all we've got time for today. I just wanted to ask my colleague Simon Day, who's on the call, were there any other comments that you wanted to make on any of the questions around sort of selection of institutions, staff, or retention, or do you feel that that's been covered?
Thank you, Susan. I think both of our speakers have covered that quite comprehensively. I'm not sure if I have much more to add. I know certainly because with regard to BHVI, we were part of that process. So I think anything that I would have had to input was already taken on. So thank you. No, I think great from both speakers.
Great, thanks, Simon. So I would like to end today by thanking all of our presenters, so Simon, Dr. Juliana and Kezi, for their comprehensive presentations and responses to all of our questions. Thank you to Emma for all the technical support, and thank you to everyone who's participated. I really appreciate you all taking time to be part of our Seeing is Believing learning community. If you do have any other questions that you'd have liked to have asked any of our presenters, you can email me after this webinar, and I'll forward your email questions to our presenters as well. And I have just one final favour. I'm now going to email you the Seeing is Believing webinar survey, and if you could please just take 5 minutes to complete it, as your support for these webinars makes them possible and your feedback helps us to improve them. So thanks again to everyone, and look forward to seeing you at future Seeing is Believing webinars. Thanks all, and goodbye.